Hi and welcome back to another microbiology question and answer for USMLE preparation. A 42-year-old wildlife researcher who has been conducting field studies in Southeast Asia for the past 3 years presents to the clinic with unusual skin lesions on his back. He first noticed the lesions approximately 2 weeks ago. The lesions are large, well-demarcated, hypopigmented macules with slightly raised borders. His past medical history includes mild hypertension. He's not taking any medications. A lepromin test is positive, and skin scrapings from the affected areas show a paucity of acid-fast bacilli. Which of the following is the most likely diagnosis? While evaluating dermatologic conditions, it is crucial to consider the patient's history, lesion characteristics, and laboratory findings. A positive lepromin test here indicates that there is a strong cell-mediated immune response, and a paucity of acid-fast bacilli suggests that there is a limited infection. The options provided here are A. Cutaneous anthrax, B. Cutaneous diphtheria, C. Cutaneous tuberculosis, D. Lepromatous leprosy, E. Tuberculoid leprosy. The correct option here is E. Tuberculoid leprosy represents the milder form of leprosy caused by Mycobacterium leprae. It is seen in individuals with a strong cell-mediated immune response. The key clinical features are usually fewer than 5 large macular hypopigmented or erythematous skin lesions with well-defined raised margins. There is scanty acid-fast bacilli in skin lesions as bacterial growth is well controlled by the immune system. There is a positive lepromin test indicating an intact T cell response. Hence, option E perfectly matches our patient's clinical presentation, making tuberculoid leprosy as the correct diagnosis. Let's have a look at why the other options are incorrect. Option A, cutaneous anthrax, is caused by Bacillus anthracis, which is a gram-positive rod. This presents as a painless necrotic ulcer with a black eschar surrounded by significant edema. However, our patient's lesions are not described this way, making this diagnosis unlikely. Option B, Corynebacterium diphtheria is a gram-positive rod and can cause cutaneous diphtheria, which is characterized by punched-out ulcers covered by gray-white membrane, often seen on the extremities. It is more common in immunocompromised patients or those with poor hygiene. However, our patient's lesions are on the back and not the extremities, and the description of the lesions does not match with cutaneous diphtheria. Option C, Mycobacterium tuberculosis can cause cutaneous tuberculosis presenting as red-brown or yellow-brown skin lesions, often affecting areas like the eyelids and face. Patients with TB typically have systemic symptoms like fever, weight loss, night sweats. However, our patient has no systemic symptoms and the lesions are not characteristic of TB. Moreover, scanty acid-fast bacilli are more consistent with tuberculoid leprosy rather than TB, which usually has a higher bacterial load in cutaneous TB lesions. And option D, lepromatous leprosy, is a severe form of leprosy occurring in patients with a defective cell-mediated immune response. These patients have multiple nodular skin lesions, severe peripheral neuropathy, and diffuse infiltration of the skin. The key diagnostic markers are a negative lepromin test due to the poor T cell response and abundant acid-fast bacilli in skin biopsies due to the uncontrolled bacterial proliferation. Our patient, however, has a positive lepromin test indicating a functional cell-mediated immune response and a scanty acid-fast bacilli, which is inconsistent with lepromatous leprosy. A 32-year-old volunteer nurse travels to a remote area of South America to assist with healthcare efforts. Several days later, she develops fever, abdominal pain, and bloody diarrhea with a sensation of incomplete evacuation. Stool culture reveals Shigella dysenteriae. Which of the following processes best describes the mechanism by which Shigella dysenteriae infects the colonic mucosa? A. Collagenase activity. B. Host cell actin polymerization. C. Prevention of phagolysosome acidification. D. Prevention of phagolysosome fusion. E. Superantigen activity. The correct option here is B. Host cell actin polymerization. Shigella invades colonic epithelial cells via M cells in Peyer's patches. Inside the cell, Shigella escapes from the phagosome using hemolysin. It polymerizes host actin molecules, creating actin tails that propel it from one cell to another. This allows Shigella to spread directly from cell to cell, avoiding exposure to the immune system. Let's have a look at why the other options are incorrect. Option A, collagenase, is an enzyme that dissolves collagen, allowing bacteria to spread through tissues. This example is seen in Clostridium perfringens, which produce collagenase, playing a role in gas gangrene. And option C, some bacteria, they survive inside macrophages by preventing the acidification of the phagolysosome. This example is seen in Mycobacterium tuberculosis. However, in Shigella, they do not survive inside macrophages. Instead, it escapes into the cytoplasm and spreads intracellularly. And option D, certain intracellular bacteria, they avoid destruction by preventing the fusion of the phagosome with the lysosome. This example is seen in Chlamydia, Salmonella, Legionella. However, Shigella does not use this method. It escapes from the phagosome and moves via actin polymerization. And option E, superantigens, they cause a massive cytokine release leading to toxic shock syndrome. This example is seen in Staphylococcus aureus and Streptococcus pyogenes.